right, guys, thank you so much. This is United Brachial Plexus Network and the Global Nerve Foundation doing a joint webinar for brachial plexus birth injuries. We've got with us three phenomenal physicians, surgeons that specialize in brachial plexus birth injuries and also adults as well. Start with Dr. Aaron Berger. He's at the Children's Hospital in Miami. Dr. Berger, what's the name of that now? Forgive me for stumbling with that, but I always call it Children's Hospital Miami, but it's actually
it's now known as Nicholas Children's Hospital.
Nicholas Children's Hospital. Thank you. He's the chief section plastic surgery, medical director for brachial plexus and peripheral nerve program, director of pediatric hand program, medical director of the wound care program. And also we have Dr. Kristen Davidge from Sick Kids Hospital in Toronto, Canada. She's with a plastic and reconstructive surgeon at the hospital, assistant professor, and associate scientist, child health and evaluation sciences, and research director, division of plastic and reconstructive surgery at University of Toronto, Canada. And coming in a little bit later is Dr. Dan Zlotolow. Always a little bit of a tongue roll pronouncing his name. He's a pediatric and adult upper limb peripheral nerve surgeon, specializing in brachial plexus injuries. Also spinal cord injuries, spasticity due to stroke, and brain injury, cerebral palsy, complex post-traumatic deformities. He's at Shriners Children's Hospital in Philadelphia and Hospital for Special Surgery in New York City. He's also professor of orthopedic surgery at Weill Cornell Medical College. All right. Well, thanks, folks. So this is going to be focused on birth injuries in the first 30 days and also covering the whole gamut more so to 2 years, but trying to help people recognize the important factors for diagnostics. And the whole intent with this with UBPN is basically patient advocacy. If we can help a patient know more about what they're getting invested into, they're going to participate more, they're going to have a little bit more control and a little bit more activity. And this is the intent of this is to help patients down the road and keep this is all going to be recorded and put on the website and YouTube channel. But something we want to start off in the books to have something that's reliable for patients to refer to and to learn from. And I know there's a lot of confusion. Me as an adult had an injury 20 years ago. It's a lot of figuring out what works, what doesn't work, and what procedure is the right procedure, what surgeon is the right surgeon. And we're just trying to help clear some of that fog out. So, Dr. Berger, I'll let you kick it in if you don't mind.
So the plan was to start by first going over the sort of anatomy and basic terminology related to nerves in the brachial plexus. So, this is an anatomic dissection of a cadaver showing the nerves that make up the brachial plexus. So in this is the location of where the lung would be. The neck is over here. This is the shoulder. And just moving from the neck towards the arm are all of those nerves that control the muscles in the arm and provide sensation back, ultimately through the spinal cord and then to the brain. And this is obviously a gross oversimplification, but the brain is connected to the spinal cord. And then within the spinal cord are nerves that then communicate with the muscles of the body to allow us to move throughout space and provide sensory feedback back to the brain. This is just a cartoon representation of a nerve interacting with a muscle. Nerves in many ways are like the conduit that runs throughout the walls of our house, the electrical conduit that runs throughout the walls of our homes. And when we look at a nerve, this is a microscopic representation of a nerve in cross section, and obviously a cartoon representation of that, showing that the nerve is made up of these cables, axons, that send signal to muscles and receive signal from sensory organs in the body. This is a cartoon representation of the brachial plexus that was produced by the Mayo Clinic that I find is very it's a simplified representation that helps me when discussing with my patients where injuries might be within the brachial plexus and how that may be playing a role in what we're seeing. So generally, the upper portions of the brachial plexus from the C5 and C6 nerve roots control the shoulder and the elbow. C7 largely is responsible for elbow extension. C8 and T1 are then responsible for hand function. You can see that represented by the color coding here. So we try to keep it simple to better understand the anatomy. When we talk about nerve injury and in brachial plexus injuries, generally, the majority that we see are the result of a traction injury, especially in the babies. These are stretch injuries. And when the nerve is stretched, it can become torn or ruptured, or it can become avulsed or torn out of the spinal cord. Now, this is a very old, this is an old cartoon demonstrating this. And this is a more recent one, again, from the Mayo Clinic. And so, at the lower end of energy are the stretch injuries that can usually recover spontaneously. The more, when the injury becomes larger or the stretch is stronger, we end up seeing a rupture injury or a tear in the nerve, and that can be repaired or reconstructed, or in some cases heal on its own. Avulsion injuries are when the nerve has been torn from the spinal cord and the root of the nerve is torn out of the spinal cord, and those cannot heal on their own. We cannot surgically repair these either. So in these cases, in avulsion injuries, usually the highest energy injuries, these are in situations in which we need to get signal from somewhere else. This is again, this is a cadaver model showing the spinal cord and the nerve rootlets and the nerve root as it leaves the vertebra. And again, a cartoon representation. These are two different cartoon representations showing what the spinal cord looks like, the nerve rootlets, and then the nerve root. Again, a cross section looking from the back of a patient. This is the spinal cord, and then the rootlets that leave the spinal cord, and then the root that leaves the vertebra to then contribute to the brachial plexus or some other spinal root or spinal nerve in the body. And what I've done here is marked out what we can and cannot see when we, as peripheral nerve surgeons. When we talk about nerves, we talk about the central nervous system being the brain and the spinal cord, and the peripheral nervous system being those nerves that leave the spinal cord. So what you can see in green is where we can get to and what we can treat. And what you see in red are the parts that we as the peripheral nerve surgeons cannot get to and usually cannot be repaired. Again, similar concept here, showing that the nerve rootlets can be torn from the spinal cord, or the lining of the spinal cord can be torn. So here you see rootlets are torn, as well as the lining of the spinal cord. And this becomes important when we talk about imaging related to nerve root injury, because you may or may not have heard in talking to doctors about something called a pseudomeningocele, which is basically a cyst that forms when the lining of the spinal cord and the nerve root are torn. So that's what we see when the lining tears, but it doesn't necessarily need to be there to have a root avulsion injury. And so these are some of the imaging studies that we sometimes get on patients with brachial plexus injuries, showing that there can be concomitant injuries or injuries that happen at the same time, such as a humerus fracture. But we sometimes see a clavicle fracture associated with brachial plexus injuries. We don't see that on either of these x-rays. And this just shows an MRI these two images are linked. These white areas are filled with cerebrospinal fluid, the fluid that bathes the brain and the spinal cord, and where there was a tear in the lining. And you can make out, to some degree, the rootlet that contributes to that root there, where there's likely an avulsion injury. And again, when we do MRI of the brachial plexus, the nerves that make up the brachial plexus, we'll oftentimes get an MRI of the shoulders as well to see how well the humeral head lines up with the scapula. Again, similar images and the details associated with MRI and how it is oftentimes, sometimes controversial as to whether we get these studies done or not, as they, in the babies, require usually anesthesia to get a good study done. But they do allow us to evaluate the shoulder anatomy, and most of us generally get them after 3 months of age as a tool to help with decision making when it comes to possible surgical intervention. So I was going to hand it over to Dr. Davidge now.
Thanks, Erin. Okay, so I'm going to talk a little bit now that, Erin has given that nice overview of what nerves are, what the brachial plexus are. I was going to talk a little bit about what happens in a brachial plexus birth injury. So if you want to go forward the slide. So we're going to, yes, yeah, it's okay. So that's a good video that Erin has put in there demonstrating a baby where you can see that the left arm is moving all around as the baby's kicking, but the right arm is not. But the hand is, and the fingers are clenching, and so there's some movement there. So, when we are seeing and evaluating babies in clinic, we all go through the history of the birth and then examine the baby. And those two things are really important for us to make the diagnosis, because there's a very often classic history of the birth and some known risk factors, and then the appearance of the arm at birth, and then how it's kind of recovered over time are all very important factors that help us to determine that a child has a brachial plexus birth injury. And we look at the entire arm from the shoulder down to the elbow, to the wrist and hand. And we do this ourselves, but often we do this as part of a larger team with our therapist so that multiple people are evaluating the baby. Okay, so why don't we go forward? Okay. So I'm going to talk mainly about the situation where the baby is being born vaginally with the head first. Breech deliveries are definitely high risk for having a brachial plexus birth injury, but they're very rarely done in North America now, or at least there are some emergency situations perhaps where that happens, but for the most part, the surgeons and the obstetricians and everyone who delivers babies, they do not tend to deliver breech. So the vast majority of the children that we see are delivered head first. And this is a picture showing a normal delivery where the baby is being born head first, and the head comes out, then the shoulders come out, and then the rest of the baby comes out. Okay, we can advance the slide. However, in certain situations, either the baby is too big, or there's a mismatch in kind of the baby size and how they're lying in the baby's tummy, and the mom's pelvic outlet where the baby has to get through in order to come out. And the shoulder can get stuck on the pelvic bone either in the front or at the back. So in this picture, the right shoulder of the baby is getting stuck on the pelvic bone in the front. And that is a situation called shoulder dystocia. So shoulder dystocia occurs in almost all of our babies who end up with a brachial plexus birth injury, but you can have shoulder dystocia in the absence of the nerve injury. So basically, when the baby gets stuck on their way out, it becomes somewhat of an emergency. The baby cannot breathe when they're stuck halfway out, coming out of the birth canal. And so their lungs are compressed. They cannot breathe. And for many of the moms who've been through this and the dads who have witnessed this or other partners who've witnessed this, it's a very stressful situation at the time. There's lots of people that come into the room. Sometimes they call a code pink because they can't get the baby out. And there's a variety of maneuvers that may be done, including pressing on the belly, changing the position of the mom, using forceps or using a vacuum or manipulating the baby. There are a number of maneuvers done to try to deliver the baby because, again, the baby's not breathing well when they're stuck in the pelvic outlet. So that can all happen in the absence of a nerve injury, but sometimes as a consequence of shoulder dystocia, with the shoulder being stuck in one position and the head is coming out the other position, you can get that stretch injury that Erin talked about in the brachial plexus in the neck. And that has a significant range of severity. So we see very mild stretch injuries that get better within a few hours or a couple of days. And then we obviously have the more severe injuries where the arm is not moving at all after birth and doesn't recover at all on its own. But that is, in general, the mechanism by which the nerves in the brachial plexus are stretched. This occurs, so brachial plexus birth injury occurs. So these are another, so just go back for a second. Yeah, so this occurs in about 1 to 3 per 1,000 live births. And that's pretty consistent in most of the developing world. And it occurs in about 4 to 15% of all babies who have experienced shoulder dystocia during the time of delivery. Okay, so we can go to the next slide. So this is just another diagram demonstrating the same thing, where the baby is getting stuck on the way out. The shoulder gets stuck behind the pubic bone. And on the left, you have the one where it's getting stuck on the front, but on the right picture, you see that the other side is the part that's getting stuck on the back of the pelvic bone, and that's where the nerve can be stretched on the other side. So it can happen on either shoulder, depending on the orientation. So we are not, none of us are surgeons that deliver babies, and we are not experts in the delivery of babies. But obviously, because of what we do and our passion for caring for children with brachial plexus birth injuries, we are obviously very well read on what causes shoulder dystocia, what is known to cause brachial plexus birth injury. So I wanted to just touch a little bit on shoulder dystocia just to better understand what are the risk factors. So there are several known risk factors. So I mentioned earlier having a big baby, and that has a few definitions. It can be over 4.5 kg. Other people have described it as over 4 kilograms. Being past your due date, that also leads to a bigger baby. So the longer you are, if you deliver at 36 weeks, your baby's going to be smaller than if you deliver at 41 or 42 weeks of pregnancy. Diabetes in the mom, whether it was pre-existing or occurred only gestationally during the pregnancy, can lead to the baby being bigger. So that's also a risk factor for shoulder dystocia. Mom's weight is also important because that can also lead to bigger babies. Older moms, for reasons that aren't very clear, having had a baby with a prior shoulder dystocia or a prior brachial plexus birth injury will increase the risk of having another baby. And in general, the babies tend to get bigger with each progressive pregnancy. And then the use of vacuum or forceps extraction when the baby is still very high up and the head has not come out yet. So those are known risk factors for shoulder dystocia, but still when you look at all of the babies that have experienced shoulder dystocia in the mom, these risk factors only explain about a quarter of the cases. So there's still a lot that we don't understand and the medical community doesn't understand in terms of why shoulder dystocia happens and how it can be predicted ahead of time. Okay, you can go forward to the next slide. So the risk factors for brachial plexus birth injury are very similar to the same risk factors for shoulder dystocia because it's obviously a big overlap. So I won't go through these again, but I had mentioned breech earlier as a separate and independent risk factors. Breech deliveries have a lot of risk factors in general, and so that's why they're not done very much anymore electively. Okay, we can go forward. So the biggest problem that faces the care of pregnant women and trying to sort out, who is at risk of having shoulder dystocia. Obviously, if one of those risk factors is present, then, it's easier to predict. But because we don't know how to predict it in most cases, sometimes it's not known that it's going to happen. It's most of the time not known it's going to happen before it actually happens. So some of the problems is that ultrasound, even in this day and age, and they have even more sophisticated technologies now, looking at fetal MRI and the size of the baby and 3D imaging. But even so, the predicted weight on ultrasound can be very much off, up to 2 pounds in either direction on the ultrasound. And then the other thing is that the baby's weight isn't the only factor. It's a three-dimensional space that includes the mom's pelvic outlet, the baby size, the baby shape, how the baby is lying in the canal, and all of those come together to increase the risk of shoulder dystocia. And it's very difficult to quantify that, even in today's age. And then, of course, as I mentioned, there's a whole bunch of unknown risk factors. And this is probably why the incidence of shoulder dystocia and brachial plexus birth injury has remained relatively static over the last several years, despite other advances in obstetrical care. Okay, go forward. So some things that have been done to try to reduce the risk of shoulder dystocia and brachial plexus birth injury. So obviously, if diabetes is recognized, having good prenatal care and controlling the diabetes during pregnancy is very important because that can help control how big the baby gets. Obviously, as everyone who's pregnant and who has been pregnant knows, that as you get further along in your pregnancy, they start to do ultrasounds more frequently to evaluate the baby's weight, how the baby is doing. They have looked in large studies to see whether you should do a C-section on everybody to prevent shoulder dystocia or brachial plexus birth injury from happening. And in some of the larger studies that have been done, they looked at if you did a C-section for everybody, you need over 3,700 C-sections would need to be done in order to prevent one more permanent brachial plexus birth injury. So there are risks to C-sections as well, which are separate from this. And so, weighing the risk benefit, that is a conversation that needs to, happen, but it's not something that all obstetrician, midwives, other people who deliver babies, they don't just leap to C-section immediately. And then when you're in a situation where the shoulder dystocia is happening, there's a bunch of maneuvers described to help deliver the baby in that scenario. But in terms of maneuvers to actually prevent shoulder dystocia, those are not well delineated as of now. And I think, yeah, so I think that's the same. So I think that was the last of my slides. Erin, I don't know. Yeah, very good. So I'll turn it over to Dr. Zlotolow now to talk about prognosis of brachial plexus birth injury and orthoses.
Thanks, Kristen. Timing is perfect because my family just got back, so they're going to be very loud. That's fantastic. Hello, everyone. This is, I'm really happy to do this. This is really great that we're doing this. And thank you to Erin and Kristen for really great talk so far. I would say there's one thing, Kristen, that I would comment on is that, and something that we tell our moms, is that if they've had a previous child with a brachial plexus injury, that's a big, big risk factor for a subsequent child. And I think you mentioned that with babies getting bigger. But I think in terms of preventing, right? We really do encourage our moms who've had a previous plexus injury to have a C-section with their subsequent pregnancies. I don't know if you feel the same way.
I do actually. So yes, 100%. So I think once you've had a baby, even a baby with shoulder dystocia, because sometimes
Yes,
you'll
agreed.
hear that. And then we strongly recommend, and sometimes moms choose to go to different providers for each subsequent pregnancy, or you move around. They may not be aware of your history. So yeah, we have certainly seen families where they have multiple children with brachial plexus birth injuries. So I think that's very important. 100% agree.
Yeah, yeah. Okay, so I'm in charge of prognosis and orthosis, as Erin had put it to me. So prognosis of brachial plexus birth injury. So why do we get imaging on some patients but not others? And why not, right? And then nerve conduction and EMG studies. So I think one of the big things with imaging is particularly getting MRIs in babies requires general anesthesia. Now, there are people looking into doing this quicker in a manner that's quicker, so they don't require general, with swaddling and maybe feeding them and getting them to sleep right before. But for the most part, in most centers, you're going to require general anesthesia. So we try to avoid it if we don't have to. And as Erin said, we really save MRIs for the patients that we're going to be operating on early. And so we try to push that MRI off as long as we can. Now, in terms of nerve conduction studies and EMG tests, I think what's interesting is that a lot of patients get referred to neurology early on, and neurologists love to make a diagnosis. And so they're going to do everything they can to sort of find, to delineate exactly what the plexus injury is. Whereas we, as surgeons who are taking care of these injuries, don't really need EMG studies or nerve conduction studies. And part of it is because studies that have looked at these studies have shown that they actually make your ability to predict outcome or prognosis is worse if you get an EMG than if you just use your clinical exam. So it actually makes your ability to predict the injury worse. So the most important. Yeah,
Why
go
is
ahead.
that? Just out of curiosity. I mean, I don't want to slow you guys down too much, but these things are.
Yeah, no, I
If I was
love.
a parent, I'd be like, what?
Yeah. So why do we not use it? Why is it actually problematic? And why do people still get it? Those are the three questions you want to know.
Yeah,
right?
basically, yeah.
Yeah. So why do we still use it? I think is because probably lack of. It's not such a common thing that neurologists are dealing with on a regular basis, and it's probably a lack of understanding of the disease process and the specificity of requiring these things in this patient population. So if you're a neurologist, you see a nerve injury, you get an EMG, that's a very common thing. It's kind of a knee-jerk response. But in this situation, what happens is the reason that we look at electrodiagnostic studies like nerve conduction velocities and amplitudes of nerve conduction, what we're looking at is, if you think of a nerve as just basically a wire conducting electricity, right? Think of it like a speaker wire going to your speaker or a wire going to your outlet, right? You can measure the amount of electricity that's going through that wire and how quickly that's moving, right?
Yep.
How quickly it's moving is a factor of how well insulated that nerve is, right? If you're losing a lot of electricity around, it's not going to conduct quite as quickly. But if it's well insulated, it'll travel very fast. And then the other thing is how much current is being carried by that wire, right? If you have a lot of current, then that means that there's a lot of wires in that one cable that are carrying that current. And if you have very little current coming across, that tells you that the wires have been disrupted, right? And so we look at both sensory and motor. So we look at both the wires that carry sensory information, that means information about touch and pain and heat and that kind of thing back to the brain. And then there's information about carrying motor function to the hand or to the arm, whatever it is, to your biceps, right? So when we look at, so one of the things that Aaron talked about was avulsions versus ruptures, right? And so the role of EMGs in adults is to look at whether or not the injury was an avulsion or a rupture. And we can tell that because what's interesting about avulsions is that they will maintain, because of where the injury happens, they will maintain sensory conduction, velocity, and amplitude, but they will not feel. And they will not maintain motor conduction. So if you see in a child that they have preserved sensory but absent motor on the nerve conduction studies, that tells you it's avulsed. The problem is not all injuries are clean, meaning it's not that you get an avulsion right away. Sometimes you get a stretch injury first and then an avulsion. And so it'll look like it's an avulsion or not, and you don't really know. So I think that makes it a much more complicated picture. And then in terms of EMG tends to overestimate the amount of potential recovery because of something called sprouting, where the nerves actually, what they do is the muscles actually start to work better than you think they look electrodiagnostically, but not clinically. And so all these nerves start to sprout and they actually can innervate a lot of motor fibers, but they don't do a very good job of it. So electrically, it looks like the muscle's more active than it actually is. And so it tends to overestimate the amount of recovery you're going to see. I don't know, Kristen, you have any other thoughts on that?
No, the only thing I was going to say is that that is more particular to babies than adults.
Yes.
Yes. So
Yes, absolutely.
everything he's saying is very particular to the baby scenario. It doesn't even apply to older children who, let's say, were in a car accident or something. This is unique. This is a unique thing to babies, where EMG and nerve conduction studies have been shown to be overly optimistic in terms of their recovery.
That was something I only learned in the past year. You know, I was injured as an adult and learned all this mostly the best I could, but the baby prospect and the sprouting conditioning, it makes sense once I understood it, but I just did not expect it. And I can just imagine, you know, parents getting information from one person or another, be it a friend or a physician, saying, "Oh yeah, you should get this for sure," and then getting another voice that says not to. It's just trying to remove the fog. And just last one with that, with the MRIs before surgery, but not necessarily for diagnostic. And is that because they're not necessarily in diagnostic tool so much, but for surgery, you're knowing what you're getting into?
So, you know, because it comes down to this: the MRI is not perfect either.
Yeah.
The MRI is much better than the EMG, and that the EMG actually worsens your ability to predict the type of injury. The MRI makes it a little bit more reliable, but it's a combination of your imaging, your clinical examination, and serial examination, which is what we're going to get into now, which is really important, is how the baby changes over time really informs what type of injury you've had. And that's very critical.
Yeah, I like to
So-
say that MRI is a very static image. It can show you that something's been injured and what nerves have been injured. Even that's not perfect, but it doesn't show you how it's going to recover, which is what we need to know.
Yeah, and for us, it's really a tool to inform our operative decision making. It is not a decision. It doesn't help us make a decision about whether to operate or not to operate. I think that that's based on the clinical examination. Again, this is pretty unique to babies.
Yeah, that's
I
important.
think MRIs in adults or even children with traumatic injuries, because it's a much more violent injury. If you think about it, a birth is not as violent as a car accident or you know, motorcycle accident, something like that. Okay, so
Thank you. I appreciate that. Helps a lot.
love it. Please interrupt at any time, because I think if you're having the question, other people are having the question as well. All right, so anyway, so that brings us to the role of serial assessment, which I think is the most important thing for examination. So you really want to measure what the baby is doing. That's motor function. And the reason we do serial assessments is we're looking for changes. We're looking for what has changed. So for example, if we have a child who has no finger function at birth, but then at 2 weeks or so gets finger flexion back, we know the type of injury that has happened in the lower trunk or in the T1 nerve root. That gives us an idea of that. If that T1 function recovers at 2 months, that's a very different picture of what we anticipate to be the injury. And it really informs the way that we treat those kinds of injuries. So knowing when things came back is really important. So we usually do our examination monthly, and then we look to see how severe the injuries are. Mild injuries where very few axons are compromised and it's mostly just the insulation of the nerve, those usually resolve within about 2 months. If you have moderate injuries, and by the way, if you resolve by 2 months, most people will say, and the data shows that those are the ones that recover fully or have very, very little deficit once you recover by 2 months. So that's sort of a critical number. And then moderate injuries where you have some axonal loss, which means you have some of those nerve fibers are torn, but not necessarily all of them. Those usually improve by about 6 months. And then severe injuries where the nerve itself is torn completely or avulsed, those improve a little bit or not at all by about 6 months of age. So avulsions, as Aaron said, really do show no improvement. And we looked recently at some of our data, and the patients who had global avulsions, meaning everything was avulsed, they had 0 movement across all patients who had that picture. So not even a hint of motion in the arm. So this is what we use to gauge motion, which is the active movement grading scale, developed at Sick Kids, where Dr. Davidge works. And this is really the gold standard. And what we do is we grade gravity eliminated function that has to be full, meaning, for example, the biceps, you have it like this, and you see if they can bend their elbow in a neutral gravity eliminated posture, and you see how much they can move. If they can do that, then you look to see what they can do against gravity. And they're assessed within the available passive range or the normal physiologic range. So this is what we use, and it's pretty commonly used, which is both a AMS scale, a Toronto scale, and the modified Mallet classification that was modified by Scott Cozen, who is my partner. And what it's looking at in terms of the Mallet, and you can't do the Mallet until they get older. And as Howard Clark says, you can do the AMS from cradle to grave, right? That's one of his lines. So I think the AMS is really, really important. I think there are problems with the AMS. It's probably not as predictive of long-term function, and it doesn't examine every movement. It gives you sort of a sense of what roots are injured, and it does give you an idea of whether or not you need to do surgery. But in terms of an outcome measure, it's not the best necessarily, but it's the best we have now. So then there's all these other things like the MRC, or Medical Research Council, which is commonly used by doctors who treat adults. And adult docs don't usually use the AMS, which actually is great for treating adults as well. And then the MRC grading system basically has this 0 to 5 with 5+, 4+, or whatever it is. And then you have the Gilbert and Tassin grading system, again, with no contraction all the way to M3. This is from the Neurakis's article defining the Neurakis classification, which is the classification that's most commonly used. And basically it divides the injury into 3 trunks. So the upper trunk, the middle trunk and upper trunk, which is called extended upper trunk. And then there's the global or all trunk injury with or without a Horner's. And a Horner's is where you get the droopy eye and the changes in the pupil. So basically, it's, as I said, the roots injured in the upper, or the so-called Erb's palsy, is C5 and C6. And then it's 5, 6, 7 for the extended. And then you have the total, which is all of the roots. And what Neurakis said, and I think has borne out to be true, is that patients who have all roots injured do the worst in terms of their prognosis. And those are the ones that really benefit from surgery the most. Although there's a lot of reasons for surgery in patients, even in the upper category, if they don't resolve. Usually patients who have Erb's palsies or 5, 6 injuries at the time of surgery that require surgery, almost all of them have had a C7 injury as well that's recovered either completely or partially. So this is sort of an example of these, the most common, of course, being the upper trunk, and then extended uppers, and then globals. But if you look at it from a surgical standpoint, and when we looked at our volume, our most common is going to be the more global for surgery, and then our least common is going to be the upper trunk. Yeah, so this is basically part of the, I think, Kristen, this is yours, right? This is the Toronto,
Yes.
Yeah, this is sort of the Toronto algorithm, which we don't necessarily follow, but it brings this cookie test, or the concept of the cookie test, which is that you give a child a cookie and they will bring it to their mouth. And if they bring it to their mouth, they have 2 things. That means that they have external rotation, and that means they have elbow flexion. So it's a test of 2 things, which is one of the reasons we don't necessarily use it, because it conflates a little bit of the shoulder motion with the elbow flexion function. But as long as you account for the shoulder motion, the concept is actually really valid. And this sort of outlines the timing of surgery. The timing of surgery generally somewhere between 3 months and 9 months, depending on the center and depending on the degree of injury. The lesser the injury, the longer we wait to see if it recovers spontaneously. The more severe the injury, the less we wait because we know we're going to have to do something. Right. So in terms of general guidelines, right? If there is no hand involvement when the child is born, meaning they are able to open their hand and close their hand, that means the lower trunk is intact and not injured at all. In those cases, generally speaking, most of those kids will do pretty well. If they have active wrist extension, so classic Erb's palsy where you have the shoulder internally rotated, the elbow extended, and the wrist flexed, that means they don't have wrist extension. Wrist extension is done by C6 and C7. So that tells you that C7 is also injured at the time. And then you have recovery of biceps, which is a 5-6 thing, and you're looking for recovery of that by 6 months. And the cookie test is by 9 months to recover that ability to bring a cookie to their mouth. The shoulder is a really big problem. It's a big deal. And the reason that's a big deal is because babies, and this is something that happens in babies that doesn't happen in adults, is this internal rotation posture. And there's a lot of work that's been done on why that happens. It turns out that these affected muscles don't grow as quickly or as well as muscles that are not denervated. And you really can't leave a baby like this because their shoulder will deform. And this is what happens. You get this posterior shoulder dislocation or subluxation. And this has been well recognized as a complication of brachial plexus birth injuries, described a long time ago and continues to be described. And you can think of it like a golf ball on a tee or ice cream on a cone, and it's kind of falling off. And you can see it's not really new, right? 1913. And what happens is, if you go to the next one, Aaron. So what happens is that the shoulder is balanced towards internal rotation, turning the shoulder in, and it's not balanced to go. It has very few muscles, only 2 that give you external rotation. And so if you denervate those 2 muscles there, the teres minor and the infraspinatus, then those muscles are not going to function, and it's going to tilt the whole thing towards internal rotation. And then the head will sublux.
Dan, do you just want to mention, these boxes represent the muscles of internal rotation, the latissimus dorsi, the teres major, the subscapularis, and the pectoralis major.
Yeah.
Just for those families that may be wondering what the letters mean.
What the boxes are behind door number 1?
Yeah, exactly.
Yeah, I appreciate that. And then there's something called the Hooter-Volkmann law, which says that compression forces inhibit growth and tensile forces stimulate growth. So basically what this means is if you take that golf ball and you put it towards the back of the joint, right, then it's going to put pressure on the back of the joint, and the back of the joint will not grow as well because the cartilage will be stunted, and the front of the joint will grow, and you'll get this sort of angling of the joint that you see there. And so this is what it looks like on an MRI. And you can see that if you imagine the T, you can see that the T has deformed and the ball is starting to slide off the T. And so this is accompanied by loss of passive external rotation. And what we've seen is if you can't get the shoulder to neutral or past neutral, that's a sign that your shoulder is really in trouble. The MRI remains the gold standard. Ultrasound has been validated for use up to 1 year of age. And we still use ultrasound as a screening tool, and we use MRI as a preoperative tool. Again, MRI is a preoperative tool for us, not necessarily a diagnostic tool. Okay. So our friends in Helsinki, Petra, Antti, and Uriana have come up with this whole protocol for dealing with shoulder, because the best way to deal with this dysplasia of the shoulder is prevention. And this is what they have described, and this is what we use, which is the teapot brace. And it helps to keep the shoulder in external rotation so that the cartilage has central loading and doesn't have that loading in just the back of the joint that forces it to deform. And what they've seen, if you go back to that slide for a second, Aaron, they've seen their rate of surgery decrease from about 30% to less than 10%. And I will tell you that we used to do about 2 tendon transfers in the shoulder a week. Now we do, if I do 1 a month, that's too many. So it's for us, it's more than that decrease.
So this is pretty huge. I mean, I'm hoping like clips like this out of the video we have here will be something that people can share and things like that, because this information, this research, makes a huge difference, you know, in the context of doing something that's not as aggressive as a surgery, but is, you know, it's passive, but it's like restrictive passive, or I don't know what the medical terms are for it, but I just think,
and it's great because it's only during naps and nighttime. So
wow.
the baby still has time to develop their muscles and their shoulder. You don't want to put a baby full-time in a cast like this for an extended period of time, but I will use a teapot brace up until 2 years of age if I feel that the child is still at any risk of loss of shoulder function. So, and that's really, that's changed my practice entirely.
It's amazing.
It's
just keeping it in place, basically, that what it's doing, or keeping it
it keeps
normative place.
If you go back to the Hooter Volkmann picture, what it does is it puts the ball in the center so that it doesn't compress the cartilage in the back of the joint, and therefore the cartilage grows evenly.
That's brilliant.
And without that deformity, once you get the child to about 2 years of age, whatever their shoulder shape is going to be is pretty well preserved from then until its maturity.
Okay.
No, it's great. So the other option is the super splint. The super splint stands for supination external rotation. One of the problems that these kids have is they lose external rotation, but they also lose supination, right? So the idea was, and then the third thing is elbow extension. So they get elbow flexion contractures, they get supination loss, and they get loss of external rotation. And so the idea of the super splint is one brace to do them all. I'm about to run out of battery. Hang on 1 second. Marie, could you get me my the plug? Thanks, love. So anyways, it's in my bag. Yeah, thanks. So the other problems, it's hard to control external rotation in the with the elbow and extension, because it's trying to basically control the rotation of a tube, right? And it's hard to stop a tube from rotating. But if you have a kink in it, like a bent elbow, that's an entirely different thing. And so that's why we use the teapot brace and not the super splint. And the other problem that we've seen with the super splint is that there's been dislocation of the radial head. And we've seen that more than a few times at this point. Give me 1 second while I plug in. All right, experiencing technical difficulties, please stand by. So that brings us to the current reconstructive procedures to enhance function. And these, what we found in our motion lab testing is that all these things may not necessarily increase motion at the shoulder. So arthroscopic release, open releases, coracoidectomy, latissimus, and teres major transfers, those are your tendon transfers that we hear about. Lower and middle trapezius transfers, which are probably a little bit more sophisticated and less often used. Upper trapezius transfer, which I think is no longer used, certainly not in babies or young children. Glenoid osteotomy, which I think is on the upswing, and humeral osteotomy, which remains a very viable option. What they don't do really is increase the motion of the joint. They just change the direction or the arc of motion of the joint for the most part. So early treatment for sure is going to be therapy, AMS to make sure you assess motor function, and also as the child gets older to do a mallet, and then institute protocols in Splint to prevent contractures and deformity. Mary Beth Izaki and the group in Texas Scottish Rite published this paper, and we published a similar paper, and Howard Clark published a similar paper looking at Botox injection for maintaining shoulder external rotation. And we found that about 15% of the time, it does serve as the only treatment you have to do. What's interesting is that now we've gone to the teapot. I think that number is much, much higher. But we will try. It's sort of when you get behind and you get a late presentation child who has not been put into a brace early, and then they fall behind and their shoulder starts to get bad, then we'll do an external rotation. We sort of accelerate the external rotation by doing a Botox and a cast. So again, these are the things to consider when you're using an orthosis or a cast or anything, is the car seat. And what we do is we have a car seat check, but getting the babies dressed, even hygiene issues, especially if you have a cast, can be problematic because babies vomit all over themselves all the time. They're like, it's like drunk people. Yeah. So next, Aaron. That's all I got. I'm going to finish with babies are like drunk people somehow. I appreciate that.
That was brilliant. Guys, if there's anyone in the audience there that wants to throw out questions, now's the time. But from UBPN and Global Nerve Foundation, thank you so much, Dr. Zlotolow, Dr. Davidge, and Dr. Berger. It just this is such a wonderful resource. I love people having information and then something that they can rewind and play again, and then pass it and share it and talk about and freeze it and then look up the word if they need to. It's just it's a beautiful thing to help alleviate some of the stress that parents and families are in the triage mode of a birth injury. I think any extra information from respected, trustworthy sources, which the three of you are, I can attest to it. I'll bet my life on it. You're not going to find better resources. So you're in the top tier of resources. So thank you so much. Any questions, guys? I don't see anything popping up. Do you guys have any questions for each other, perchance?
I put a plug back in for the camp because I think that's probably that in and of itself is an outstanding resource for families to make use of. I think many times patients and their families feel as if they may be the only ones dealing with this problem, and there are a fair number of people throughout the country that are going through the same experience. So I think that the camp is an invaluable resource, and you guys, the leadership of the UBPN, having come to all of the scientific meetings and scratched beneath the surface and realized where all the holes in our understanding are at the peak of sort of the resource availability for patients and their families. And
Thank
Kim's indicating that she still has 8 rooms left at the lodge, I guess.
Awesome. All right.
I haven't booked mine yet, but I am going.
Oh, good. Fantastic. That's fantastic. And I'll just
this will be my first experience too. I haven't booked it either, but I'm going to come. So
great.
I'm really
Fantastic.
looking forward to it. I'm very excited.
The context for me is a little different with campus. I have a traumatic injury and I had when I was 34, but the essence of community and what it does to the soul and the mind and the heart, because if those are dysfunctional, your actual healing is not going to happen very well. If you're in a stress state and you're not like feeling connected and you're feeling lost and you're scared, those things are not going to help you heal. Whatever it is you're healing, as a parent of or the child itself, and the camp really it touches on all those beautiful sacred places. It's really a wonderful thing to have, and nothing is worse than feeling alone when you're in the middle of a misery. You have someone to connect with and share notes on, and get some hope from, and help someone else also. Say, I went through that. I can help you with that. We've been there. It's just a beautiful experience. And then to have so many physicians come in that have Q&As and discussion, and it's a real. We got some questions coming in. Great. It's just a very, Kimberly, thank you.
So Antoinette asked, what resources do you have for adults with Erb's palsy? That I assume she meant the camp is for children and their families, right? And Antoinette, the camp, my experience with the camp was that, and I'm sure Kim can attest to this. I don't know, Kim, can Kim speak up or not? I can speak on her behalf. based on my experience there, is that the camp is for all of the above. And it's fascinating. And I think most educational, one of the things that I found most educational was sitting in and listening to some of the adaptive strategies that kids and adults had come up with in their roundtable discussions for how to deal with a disability and also how to deal with bullying throughout life. So there are, yeah, Kim just piped up with all ages. So to answer your question, yes, the camp is for people of all ages, and there are sessions devoted specifically to adults with who had brachial plexus birth injuries.
Yeah, and I was mentioning the difference with me as being an adult that had my injury. I was only meaning that the place I first found that was like Challenge Athletes Foundation is a one space, all these other athletes, different thing, but camp is absolutely all ages, and it's really wonderful. And you know, it's an injury that can carry on for your whole life, the duration, and learning how to deal with things and the ongoing struggles with overuse and things like that. Information and compassion and love is just shared between everybody, and it's a fun experience. So all ages welcome completely, and that do come. Very good question. I think that wraps us up right on time, guys. Look at that, 6 o'clock, on my time at least. It's 9 o'clock, you guys. Thank you all for your different time zones. I really appreciate it. And I hope no one skipped any meals for this. If you did, get some food fast before it gets too late. Thank you, everybody. Thanks for the questions. Thanks for the surgeons and for Global Nerve Foundation getting this kicked in too. Take care, folks.
Thanks very much, Chris.
Thank you so much.